So next we have Justine Mallatt presenting controlling costs through soft spending limit by Maggie Shi and Ashwin Gandhi.
Good morning. My name is Justine Mallatt. I'm with the Bureau of Economic Analysis, and I have the pleasure today of presenting a paper by Maggie Shi of University of Chicago and Ashwin Gandhi of UCLA called Controlling Costs and Soft Spending Limits: Evidence from the Medicare Therapy. So standard disclaimer, since I'm an employee of the federal government, I have to say that the views expressed here are those of the authors and discussants and don't represent the views of the US government, Department of Commerce, or the DEA. So to motivate this work, Maggie lays out that governments and firms delegate expenditure to agents who may privately gain from spending. So agents make their own spending decisions and they might have an incentive to overspend because it's beneficial to them, which may lead to inefficient spending. So the governments or firms monitor spending, but monitoring every single spending decision is infeasible and costly. So one solution that's commonly used for budgets and accounting is soft spending limits, where they set a cap and you have to do additional paperwork or justify spending above a certain cap. Examples of this include procurement thresholds and project budgets. We'll give you a dollar amount that you can't spend over, but you can maybe spend over if there is a good justification for doing so. So this is a way to screen out wasteful spending on the intensive margin via monitoring or by inducing efficient sorting around an ordeal. So efficient sorting around an ordeal is people that would have more value in surpassing a soft spending limit are going to be more likely to try to jump through the additional hoops for the soft spending limit. And this may give unfair advantage to those who are better at navigating rules, doing paperwork, who are more charming to the people in charge, all sorts of unfair advantages. So we're dealing with an instance of a soft cap in healthcare. In this case, insurers are delegating spending decisions to providers and patients. So providers in this case are acting on behalf of themselves and patients. And there's a lot of potential wasteful spending in healthcare. A paper by Cutler from 2018 finds that 1/4 to 50% of medical spending is unnecessary. And a recent paper by Abe Dunn and co-authors, Abe Dunn is my boss, so shout out, finds that paperwork requirements in healthcare are cumbersome to providers, and they favor large providers that are more sophisticated with their billing departments or have better employees and deal with more claims. So the context here is there's going to be a per patient annual limit on physical therapy spending within Medicare, which can be bypassed if a provider can attest to the medical necessity of spending above the soft cap. In 2006 is when this policy goes into effect. Medicare is setting the soft limit of about $1,700, $1,700 plus 40 per year in physical therapy spending, and this $1,740 is equal to about 10 weeks of physical therapy in the claims data. And this is mostly comprised of therapeutic exercises and manual therapy. Patients are spending about $170 a week getting physical therapy from providers. And a provider can submit extra documentation of patient need on a claim to get permission to spend above the soft cap. And this will be reviewed by the adjudicators at Medicare. And if they've done the paperwork right and the patient looks like they need the care, the Medicare office will be more likely to approve that claim and pay for it. So here we've got a patient going to the provider, And the provider is going to determine whether or not to provide care to this patient on the intensive margin. So if they think that the patient is pretty healthy and has had a lot of care already, and they might be likely to be denied by the insurer, they might just say, oh, you're kind of up against the cap, or you're spending a lot of money. If we file this claim, we might not be approved to give you this treatment. Then the provider is deterred from the soft cap law. Whereas if they want to spend over the cap, they have to now file more paperwork through Medicare, more documentation, and there's a chance that they might be denied if they spend over the cap, even if they file a claim. So there's going to be savings in Medicare from this policy, and she and Gandhi look at this deterrence channel and also this denial channel. So the authors take a deep dive into how this soft cap is working. It's a really in-depth investigation into how the policy is working. With most health policy research, researchers would ask, is this saving Medicare money? And then answer the question with like a diff and diff or something straightforward, do a few robustness checks, and then call it a day. She and Gandhi delve way, way deeper. They look into all of the mechanisms and how providers are navigating paperwork. So first they look at the effect of the policy on expenditure. They measure the amount of savings associated with this soft cap going into effect, and they decompose the savings into deterrence and denial channels. So they look at the mechanism of action. And they also look at the dynamics of the savings amount over time. Does this soft cap get less effective over time? And then they look at what impact the policy is having on patients. So the policy is meant to deter spending on over a certain cap for those that are healthy and are spending wastefully, while preserving the ability for less healthy patients that need physical therapy to keep receiving it. And so does this policy targeting have different effects on sicker versus healthier patients? Are patients and providers sorting efficiently around that ordeal? And then they also look at potential spillover effects onto non-physical therapy health outcomes to see if when patients are getting cut off of their physical therapy, is there evidence that they might be substituting to other forms of pain management as well? And then they're going to look at the provider side and how they're dealing with this cap. They're going to look at heterogeneous effect of this cap policy on providers based on the provider's size. They're going to find that large providers are better at getting claims approved. Large providers are better at navigating this documentation and paperwork that is introduced with this policy. And they also document how firms are learning to navigate the documentation process over time. So jumping into the data, they've got the 20% sample of Medicare enrollees and all of their claims. They're mostly going to be focusing on the 2004 to 2008 period, since the policy goes into effect in 2006. And they're also going to compare it to 1999 and 2000 because there's a previous hard cap on physical therapy spending in 1999 to be compared to. And they're going to isolate beneficiaries with in-office physical therapy. These beneficiaries have to have at least 5 weeks with $50 or more spending in the weeks in the calendar year. And it leaves a pretty large sample of 187,000 patients in 2006 and 170,000 patients in the pre-period 2005 to compare to. Providers are going to be identified by their tax identification number. So providers are, this is a practice level identification measurement of providers. So we're going to be looking at physical therapy practices as our provider. So in measuring deterrence and denials, they cleaned the claims data in a certain way that I thought was very clever and intuitive. So they work with the data at a patient week level. For each patient and physical therapy claim, they determine the number of weeks away that the patient is from hitting the cumulative soft cap during the claim that's being looked at. So for patients who end the year with physical therapy spending above the cap, 0 is the week in which their spending crosses the cap. And for patients who make an attempt to spend over the cap, a claim is filed, but then they get denied or never get past the cap, their last week is going to be the week -1. And for patients who never make an attempt to pass the cap, they use past spending of patients to estimate how many weeks the patient is from hitting the cap that had they continued receiving care based on their past moving average consumption and their past average consumption. So an attempt to cross the cap threshold is when a patient's spending is below the cap at the beginning of the week. And then during the week, they're billed, there's a claim on file that's billed that would push them above the cumulative spending cap. And then a patient's approach is the weeks before the first attempt that they try to cross the cap, or it's the weeks before the extrapolated week 0 if the patient doesn't end up attempting trying to cross the cap. So if a patient makes an attempt to cross the cap, like a claim is filed, Medicare is billed, but their Medicare denies the claim, a patient is denied. And then a patient is deterred if they spend all the way up to the cap and then stop short and don't file a claim. So evidence that denial rates change once there's a cap in place. You can see in 2005, this is before the cap is in place, patients are approaching the $1,740 cap, which would happen in week 0 in 2005. And there's just smooth probability of denial for their claims. Whereas when the cap goes into effect in 2006, patients are much more likely to get denied when they cross the threshold, when they attempt. So they use a bunching methodology to calculate the effect on spending. In this graph here, we've got the distance from the cap by the end of the year of patient spending on the x-axis. So 0 is the cap amount at the end of the year. You can see in 2005, the share of patient spending at the end of the year around the cap is very smooth. Patients are just as likely to spend just below the cap, just as likely as they are to spend just above the cap. In 2006, there's immediately this bunching pattern where patients are spending all the way up to the cap and then stopping short right at the cap. And then they're less likely to be spending over the cap at the end of the year. Oh, and this is, they use this type of methodology to calculate the distribution of spending in 2005 around the cap and the distribution of spending in 2006 around the cap. They hold prices per service constant between the 2 years, and they calculate the difference in Medicare expenditure and find that there's an 8% reduction in physical therapy spending in Medicare due to this cap. And that is equivalent to about $152 per additional denied claim. And here's a placebo. This is comparing 2004 that had no cap and 2005 no cap. So there's no difference in the distribution of spending around the end of the year around the cap in either of these 2 years. All the action is happening in the treatment year. Comparing to the hard cap in 1999, here we've got a similar setup, except for 1999 had a hard cap of spending at physical therapy, but in 2000 it was completely rescinded because it was very controversial. So 2000 is used as the counterfactual here, which it looks like an okay counterfactual. Again, there's smoothness along the threshold that existed in 1999, and with this hard cap, they find that there was a 16% reduction in physical therapy spending. So the hard cap that has a strict limit was about twice as effective as the soft cap with a limit that can be surpassed. So then they look at the deterrence and denial channels. So this graph is the difference between the distributions in 2006 and 2005 around the cap. So what's important to notice here is that in the treatment year in 2006, there are fewer patients that have spending above the cap, and then they're all bunching below. 40% of this is due to the deterrence. So patients spending all the way to the cap and then stopping short of filing a claim that would cross the cap. And then 60% of the effect is due to denial. So the pink part of the bar just below the threshold there is patients that attempted to spend, or providers that attempted to file a claim with patients spending above the cap and then were denied by Medicare. So the soft cap was meant to curb wasteful spending on physical therapy while preserving access to treatment for patients with high need. So now we're going to look at policy targeting. So our patients that are considered high need, which is going to be measured by calculating expected spending for the patient, are they less deterred by the policy, and are their claims less frequently denied? So the theory here is that starting with this left-hand side graph, we've got patient need on the x-axis and either the probability of being deterred or denied on the y-axis. So here you have patients with low need. These are going to be healthy patients, and they're going to be more likely to be deterred or denied in the pre-treatment year. So they're going to be just kind of coincidentally clustering below the threshold. They're going to have lower average spending than the less healthy people around the threshold. And they're going to be denied at higher rates because they just are getting wasteful care. And then if the cap goes into effect, and it'll move the rate of denial up and rate of deterrence up. If it does it in a way where the slope stays parallel and it's an upward level shift for both healthy and unhealthy patients, that means that there's not efficient screening going on. It means healthy patients and less healthy patients are suddenly both more likely to be deterred or denied in a way that doesn't represent there's a lot of thoughtfulness going around the decision. Whereas on the right side, here we've got improved screening on need. The patients with lower need are more likely to be screened out with this process than higher need. So this is on the right side, we would want to see this pattern if the policy is working more efficiently here. And to measure patient need, they predict what patient spending would have been in 2006 in the absence of the cap. So they train a machine learning model based on 2004 and 2005 data to predict what patients in 2006 should be spending. They rank patients based on their anticipated need in 2006. So the machine learning model uses lots and lots of different measurements of patient need in the claims. They kind of throw the kitchen sink of measurements into this machine learning model and then let the computer decide what types of characteristics in the claims determine spending best, are most associated with differences in spending. And then they use that machine learning ranking to classify patient need. So here we've got the outcome deterred, and you can see that in 2005, patients that have lower predicted spending, lower need, are more likely to cluster just below the cutoff than are patients that have higher predicted spending, because the higher predicted spending are going to flow past the soft cap. It doesn't exist yet. And then in 2006, this shifts up in a way that suggests a level shifts. So this suggests that there's not a lot of screening for patient need. The less healthy patients are getting deterred care at an increased rate, which is the similar in the change of magnitude of the more healthy patient. And then contrasting this with denials, if patients receive care and file claims to try to get a reimbursement from Medicare, Medicare is denying the patients that look like they have less need at a higher rate than patients that look like they have greater needs. So there's evidence of screening on the Medicare side when the claims are, they're deciding whether to approve or deny the claims. So they also, I'm going to hit on this briefly. I have a bit more to go over. So they also look at potential spillover effects of getting cut off of physical therapy spending in the treatment year. And here they use a natural variation in when a patient is first starting physical therapy. So there, people getting injured in the beginning of the year and getting physical therapy are just much more likely to hit the cap over time, whereas the folks that get injured in November don't have enough weeks left in the year to hit the annual cap by the time it resets in January. So there's evidence that there's a reduction in spending among those that get injured earlier in the year compared to those that get injured later in the year. And then so because those folks are more likely to run up against this cap and get cut off, there should also be patterns in these substitute pain treatment options if they're turning to substitutes. And there's no evidence of a mirrored pattern in any of these other outcomes, which means that there's no evidence of substitution. So now looking at the provider side, measuring provider size by how many physical therapy patients does a provider or practice see. And the rate of deterrence they find that the rate of deterrence isn't correlated with provider size, but the rate of denials decreases as provider size increases. So showing this in a graph, here now is those deterral and denial graphs, but now with detail on the size of the provider. So in the deterred side of the graph, the small providers, which are the triangles, and the big providers, which are the circles, have very similar patterns in the pre-treatment period, and then they're getting deterred by the policy in a very similar way once the policy goes into effect. And then on the denial side, neither large providers nor small providers are getting a lot of claim denials in the pre-treatment period. But then 2006, the cap goes into effect and the big providers realize an increase in denial rates, and the small providers realize an even larger decrease in denial rates. So size matters when it comes to denials. So the authors argue that this is occurring because large providers are better at providing documentation, they have more sophisticated billing practices, and their billing departments are more on top of things. So the documentation requirement in this policy is that Medicare says if you file a claim for PT spending above the limit, you have to use this KX modifier code on the claim. So there's kind of a secret code that needs to be used just when the spending is over the soft cap. So this documentation really matters in getting a claim approved. In a regression on the denial probability of each claim, adding documentation increases the model fit most, and adding documentation is highly correlated with getting the claim approved. And then furthermore, they use a machine learning model to predict denials in the claims data, and that machine learning model also spits out documentation as the thing that really matters in determining approval. In contrast, patient characteristics have almost no power in measuring denials. It all seems to be baked into whether or not the provider puts this KX code on the claim. And if you need more evidence of this, the share of claims with documentation and the share of claims that get approved are just right on top of each other in a graph. It's the same picture. So now, this is kind of my favorite part of the paper because it was clear and interesting and I haven't seen it done before. The authors fit a linear model to try to see how providers are learning about the documentation over time and getting their claims successfully through Medicare over time. So they're going to be fitting this linear model with time invariant patient characteristics, patient medical consumption patterns that vary over time as controls, provider fixed effects, which provider size will be baked into those, and time fixed effects to capture industry-wide learning about the documentation. And then they're going to measure provider experience. Each provider and each week is going to have a cumulative amount of past attempts that they've tried to get claims over. So this is kind of practice. As providers see more patients, file more of these types of requests over the soft cap, they're going to get experience over time. So here's the linear model. What we're going to be interested in is the cumulative attempts of providers over time, and then provider fixed effects. Maybe large providers just have an inherent advantage that's time invariant. And we're going to look at all attempts to bill past the cap in 06 to 08. And so the coefficients associated with the number of cumulative attempts is positive. So this is representing learning by doing. As providers get more cumulative attempts at passing the soft cap, they get better and better at getting those claims approved. Provider fixed effects, just graphing provider fixed effects and their ability to get a claim approved in a time invariant way, and then putting it against their size. There's a clear positive relationship between provider size and just their inherent advantage in getting a claim approved. And then this was also interesting. Large providers see more patients, and so they accumulate experience around the cap quicker than small providers. So not only do they have an inherent advantage and learn over time, they learn more quickly over time because they're accumulating experience more quickly. So if that wasn't convincing enough, they look at an instance of sharp learning. So what happens when a provider first successfully reverses a denied claim by adding documentation? So they file a claim over the cap to Medicare. Medicare sends it back, says you need this documentation on it. They put the documentation on the claim and it gets through. Is the first time that happens to the provider is the treatment here. And you can see that providers immediately start adding more documentation to these claims that are crossing the cap. So this was very convincing as well, that there's an instant learning going on once this happens. So because there's all this learning over time and providers are learning how to navigate the paperwork of the situation, the savings gleaned from this policy decrease over time. So in 2006, there was about an 8% reduction in expenditure due to this policy, and it falls to 5% and 4% in 07 and 08. And decomposing whether the deterral channel or the denial channel is driving this, it looks like it's mostly the denial channel, and it's this learning through doing. So kind of wrapping up, there's 8% savings due to this policy, and deterrence is about 40% of savings, denial is about 60%. Providers are deterred, and they are deterred in a way where they don't pick which patients to not treat based on the patient's need. But Medicare is more likely to approve attempts from patients that are measured as high need. So there's some policy screening going on, but the burden is all on Medicare and not on providers. Large providers have an advantage in successfully documenting patient need here. They've just got a fixed advantage, and then they learn quicker over time. And the soft cap has created savings. So the upside is the soft cap's created savings for Medicare and doesn't lead to spillovers on other patient outcomes. But it's doing so in a very strange way. It's got compliance costs. The screening is imperfect. It intentionally favors large providers, which the authors eloquently say this introduces horizontal inequity along a dimension unrelated to patient need. And it has diminishing effectiveness in creating savings over time as providers learn how to get around the policy. So running a little low on time. My suggestions for this paper are really minor. My job is easy. The paper is excellent. I think it's been through several rounds of revisions and comments, and it is very airtight in what it does. So this is some of the best applied work on healthcare claims I've ever seen. It really demonstrates deep knowledge of claims data. It reveals meticulous consideration of policy. It takes full advantage of a broad range of econometric methods. It's very well written, well explained, and set well in the literature. And the visual results just kind of speak for themselves and are really visually compelling. Gia and Gandhi make this look easy, and I know it wasn't, so bravo. I've got a couple recommendations that should just be taken as light suggestions, because again, this paper is very polished. So I was interested in fleshing out the deterrence channel. A lot of attention is put into figuring out what's going on with documentation and denials. Is there a way to try to document learning around deterrence? Maybe providers think that this is a hard cap and then later realize, no, I just have to this is actually a soft cap and change their behavior. So I'm interested in seeing if there's bunching up to the spending limit, which indicates a lot of deterrence, and then suddenly there's a learning event and the deterrence rate goes much like further down. They start treating patients more. And I'm also concerned that providers may be upcoding more generally. So they realize, oh, there's more documentation needed to get over a soft cap. We're going to start coding patients' diagnosis codes as more severe than we did before. Or alternatively, they might say, oh, there's a lot of scrutiny in physical therapy spending right now. And we might have to tread lightly around the cap and maybe underbill a little bit to make sure that it doesn't look like fraudulent charges. So this types of behavior might affect the amount of savings that Medicare can claim from the policy. And I have a few more minor comments, but I think I'm out of time, so those are very minor. Thank you.
Great. Thank you so much, Justine. I was thinking as you're presenting, I should just send you out to like go and do my talks for me. Like I don't need I don't need to be there. You've covered it in much in really great details. Like, I really appreciate you reading it and giving us these comments. So I'm just gonna go back, put the comments back up. Yeah, so I really like this point about like the deterrence channel, I think, or kind of diving more into the deterrence channel. Because something that was sort of striking to us, and like we can't tell if it's a bug or a feature of this paper, is the fact that we don't find that the providers are kind of being very rational. Like we don't see that they're screening on need when, like Medicare, or like the denial rate that Medicare is sort of, Medicare's denial rate reflects screening. And so you would think that like providers would sort of backwards induce and realize like I should also screen too, even if I don't care about my patient, simply because there's revenue on the line. And then the other thing that really confused us also was like, we don't find a difference in deterrence for big and small providers when you see there's this huge gap. Like small providers are twice as likely to get denied. You would think that they would sort of infer, for whatever reason, I keep getting denial, so I should be more deterred. And so we, it's not in the paper, you've seen the paper, there's like so much in it already. But we did run some analyses looking at like, is there learning in deterrence? Because we do see like some reduction in deterrence over time. They do get a little bit more aggressive. And so the learning event there that we use is after the first time that you have a successful denial, or rather a you successfully overturn a denial using documentation. So kind of like the first time we see you turn that on, we look at your subsequent attempts. So are you more likely to make an attempt if you have now turned on, documentation, or you figured out the secret sauce? And we do see some evidence there of learning. And so to your point, so is there evidence that providers thought this was a hard cap? I think there is evidence that, or my read of the evidence on our paper is that there was a bit of confusion about the policy itself. And so I think many of them may not have even realized, especially small providers, that there was a cap there, because if they knew that the cap was there, if they knew they had a high denial rate, they should have been trying less, but they were trying just as hard. And so the hard cap was like 7 years before the soft cap. So I don't know, maybe with turnover of PTs, like many of them they weren't there during the hard cap. But I think what actually happened is like they just thought that there wasn't a cap, and a lot of them just tried to blow past it. And then over time, these like changes that we're seeing are kind of because Medicare is conditioning or like correcting the providers. And something that I have yet to look at, but I really want to dive deeper into is like, in later years, do we see better screening on deterrence? Are they learning what Medicare wants? And so, yeah, more to do in this paper. And then on this question of upcoding, this is a really good idea. I actually had not realized that like we sort of force prices to be constant to make the comparison across the years the same. And so we didn't want, you know, like savings to be distorted by the fact that procedure prices change over time. But there is, even within year, there's variation in the prices for the procedures. And we've sort of shut that down. We like normalized that. But I think you're completely right that may the price that a provider gets for the procedure may be related in some way to the way that they code the rest of their claims. And so we haven't, yeah, so you're completely right that we've shut that part of the story down, but maybe we shouldn't. And so I think the first thing that I would look at is exactly what you suggested, which is like, do we see differences in the usage of certain diagnosis codes? There are a few diagnosis codes that are sort of more malleable than other ones. And so we can definitely look at if they change that. And then I like the idea of, like, I had always thought of it as like, oh, they're just definitely gonna upcode because you make them look really sick so that you have the documentation, you also have the diagnosis code and the claims data. But this, like, the treading lightly around the cap is actually really is very interesting. Like it could go in the other way, where we see that they're getting corrected about documentation. Like maybe they're also because they're getting corrected by Medicare, they're like, whoa, I'm on Medicare's radar. And so I need to be a little careful. So it could go either way. And we haven't looked at it. Okay. Then I think, I thank you for reading all the way to Appendix C. I just want to say, yeah, because I think you put a figure up there that was like from the appendix, and I was like, just seen as appendix. Okay, that's all I have in terms of comments on the discussion, but again, thank you so much for super in-depth discussion.
That and we'll kind of work our way down the rows, so.
Okay, so love the paper and great job, Justine. Like discussing bulletproof papers is really hard. So hold on. One of the things I was curious about is I have no idea if this is true. Is there any way that you can pull out information from the claims data? Is there anything in there that looks like you could measure patient progress? So like if we think about like just the type 1 versus type 2 errors, can you, if you know the optimal sort of stopping point relies on diminishing marginal returns, is there anything like that that you can see?
Okay, so let's see. What we have not done much on is like looking at what patients' claims look like once they start PT. So like all of our like prediction stuff is based on just like what do you look like from the day you start PT.
Right.
But so we haven't looked at measures of patient progress. I think the way to do it would be something along the lines of what Justine recommends, like looking at the diagnosis codes, but it's also like intertwined with her point of like the once the cap is in place, the diagnosis codes also serve as like in addition to tracking actual progress, they also serve as like a place to potentially signal. And you can like upcode or pack things into there. But that being said, I think that there are definitely there's like these smaller ICD codes that are like the softer measures of progress. I remember there's one about like stature, like how well the person can stand, and that's not usually like the first diagnosis code.
Right.
It's like the third or the fourth one. And so yeah, we should definitely dive more into like what the diagnosis codes look like once they start care, and see if we see these like softer ones either going away or actually getting worse. Like,
okay, and then sorry, the other just quick follow up is there any way? I don't know anything about how Medicare would or would not audit provider claims. So the different providers, like, no, we're going to write some stuff down about your knee so that you can get another month because you need it. Like, is there any way that CMS can kind of call BS on that?
Not so. In theory, yes. Like in theory, they can like request all of your documentation and they can rescind things. Like even if they paid for something, they can take the money back. I think in this, like for big ticket items, we see Medicare really being willing to do that. For since like $170 a week, it's not clear to me, and like we haven't been able to find good evidence that they're going really in depth with auditing for this particular policy, but they can at least hold over the head of like providers, like we can do this. We are like legally allowed to go in and probe.
Leila?
Yeah, so I guess my question's on similar lines, but I'm really obsessed with trying to resurrect the part of your paper that like I'm sure you wanted to see like on the kind of what's the efficacy of like increasing PT, and you have these kind of like
Yeah.
graphs showing no effects on surgery and so on.
Yeah.
And in the effort of like seeing if there's any way to like find a thing there, I was wondering if you thought about splitting your cohort for patients with different indications. So like post-surgery PT, right, is trying to like improve their recovery, but probably not stave off surgery. So in that population, like maybe we'd look at, do they need assistance with ADLs? You know what I mean? Like if your hip surgery doesn't heal properly, then maybe like you actually can't do ADLs and you use more home health care.
Yeah.
Whereas if you like trying to get PT to stave off a surgery, like you haven't had surgery yet, and you have back pain and you're trying to avoid surgery, then maybe like
Yeah.
getting orthopedic surgery is a good outcome. So I'm wondering if by subsetting your population
Yeah.
and matching the outcome a little bit to like the condition,
Yeah.
I don't know if it will help you show anything there, but it might help you tell at least a tighter story
Yeah.
about like, is there clinical benefit?
You're completely right that there appears to be two types of patients who are in our data. So they all have like the same diagnosis of like I've got a hip problem, but then because we were looking at like how many of them have had a surgery and how many of them will get one, and it's like split. It's like 20% recently had a surgery, so the PT is post surgery, and then like another 20% sort of like either the PT failed or like the PT was in preparation for a surgery. We've split by like high versus low predicted need, but it's a very black box, like kind of, our prediction is just we throw the kitchen sink at it. But I like this idea of like being a little bit more principled about it and saying like, there are clear categories of types of patients who they're in PT for different reasons. And so maybe the outcomes that we should be looking at for those patients should be different. Like if you already had a surgery, we shouldn't measure if you're going to get another, or I guess if the surgery failed, but like most likely it's not going to appear as another surgery. Yeah, I really like that idea. And I think that the types of patients in our setting are actually, it's not so many different cases that it's impossible to do that. I think there's some pretty clear cut categories that we can make.
This is really fascinating, and I understand it's a paper about, how did a policy kind of change behavior, and it's not really about like welfare per se, but I guess I'm curious if, and it's I think related to the last question, like if we can say something about it, and I guess there's a couple of things that I would like to tug on. One is just, where have we decided that like wastefulness begins? Because, is this the optimal way to sort of be doing? Is this the optimal amount that they've decided on? And then the other one is, this is costly to do this like paperwork, and it's just, how much is that? If you like subtract that out, maybe these costs are just getting passed on in one way or another to just somebody.
Yeah.
And then I guess I also was just curious, like, if Medicare is doing this, and then providers are sort of figuring it out, and that's just like the kind of equilibrium, that we're in. Do they kind of change stuff? Like, like this, it always seems like it's a bug, maybe it's a feature where they're just kind of like, suddenly this documentation doesn't work anymore.
Yeah.
And I'm just curious, do we know, like, if that's like consciously something that they do, like, okay, we're gonna do a switch.
Yesterday.
I should have asked yesterday.
Yeah. I should have asked her yesterday.
Yeah.
Okay, so I'll start with your first question. So the question of like, what do we have to say about welfare? We've grappled with a lot, and it's tricky, and it's like intrinsically tied with your second question of like, what is waste, right? And so the way that, I think the welfare question would be easy to answer if we saw that this thing was like killing people, or like, we can't go with that answer. So then we have to unfortunately think a little bit harder about it. So one thing that to highlight is that basically what we're looking at is the targeting, not of like overall healthcare dollars, but rather publicly funded healthcare dollars. And the reason I make that distinction is that anecdotally, what is happening for a lot of patients after they hit the cap is they keep going, like they keep spending. The healthcare dollars keep getting spent. They just spend for it out of pocket. And so, but it's not all patients, and we don't have a good measure of like who does and doesn't do that. And so, our take on like what is waste is kind of just based on what Medicare says is like they want medical need, and clearly like whatever we are predicting with our ML measure is correlated with what Medicare cares about because it's what they deny. But and so our paper is thinking very much like, okay, if you are Medicare and you have some objective about how you want to spend your publicly funded dollars, like how well are we achieving that? I think the broader question of welfare is tougher because you know, like if people are willing to pay for their own PT out of pocket, I guess like Medicare doesn't really care. And so in our paper, we sort of don't take a stance on welfare because we basically don't think about what happens after the cap. But yes, it's kind of like an unsatisfactory, or like that's the where we've gotten ourselves in terms of like thinking through this. Is like, you know, what's to say, like that could very well be waste from a societal point of view, like that the patients who are paying for every week I go in and like someone massages me, that the opportunity cost of like that visit could actually be quite high because there's someone else who's waiting in line. But like, at least in terms of from Medicare's point of view, they're not using public funding to do that. And so from Medicare's point of view, like it's successful that they have passed this cost on to consumers and then or to patients. To your second question of do they like experiment a lot and like what goes into Medicare's thinking of like when they try to do something like this. So I've tried to read the tea leaves about what they're trying to do. Well, I can tell you what the history of like what happens after. So so PTs hate this, and the National like PT Association has like one and only one goal, which is to every year go around and talk about the PT cap. And so like every year they like complain about this. But it's stuck around, so it's like all the way up until 2024. And so the only thing that Medicare is really like innovated on is changing where the cap is little by little, like $100 increments at a time. But we look even further beyond 2008, and our like the savings results become indistinguishable zero. And so it seems like pretty much everybody has adapted. And it seems, if I were to say like in the year 2024, it seems like it's just like kind of a whole, the whole thing is sort of a waste. It's like the PTs have figured out how to get around it. Medicare is still possibly like putting some money into doing some denials. But it's kind of this like gentleman's agreement of like, we're now at this new equilibrium where everybody gets passed anyway. And they haven't experimented much beyond that.
Ginger?
Yes, I really love the paper. It's the pictures are striking. I'm wondering whether there is a third channel. Maybe I'm too ironic here. So suppose there are patients who would not have taken 10 weeks, but now the Medicare put a focal point on the 10 weeks, and then there are like less patients in the office for the therapist to treat. So the office could say like, now let's overtreat those people who would not subject to this paperwork burden. Can you distinguish that from the other two channels?
We talked about it. We call it the like seminar dinner phenomenon, which is like, at least at Harris, they give us $100 per person, and so we always try to get very close to $100 per person. So we let's see. So it's kind of, it's difficult to do that because that would also appear as bunching. And we look at where, okay, so actually we have done something similar to it. So we've looked at where in the distribution of predicted spending are the patients coming from. And so a story like that would show like a lot of the patients who are showing up in our bunching part, post reform, they're actually coming from the left side of the distribution.
Mhm.
And that's not what we're finding. At least like they do appear to be coming from the right side. What else was it? Oh, and then on the second question of like crowding out. So we were also a little bit worried that one potential, or we were just worried that another way that this reform could change who's getting care is about changing like the overall capacity of providers. So, now that I'm stopping prematurely for patients I used to treat, like maybe I'm gonna take more patients on the excess margin or something like that. And we looked at that only on the Medicare patients. So you would expect basically providers who ex ante have more patients that would be close to the cap. They should have the biggest increase in capacity. So you would expect increases on the excess margin to come from those guys. And we don't find evidence of that. And I think the reason is that actually like this part of the distribution, even for Medicare patients, is actually a pretty small part of the distribution. I think the average PT that people are getting is actually not even close to 10 weeks. And Medicare is also just a small fraction of revenue for these providers. And so my sense is that it is not as big of a policy change in terms of providers' bottom line, where it's affecting like their overall capacity.
Okay,
All right,
thank you.
great.
Soft cap on time, but people who have additional questions, we have about 20 minutes before we start the next session at 10:30.